MRCP Part 1 aspirants and our honorable faculty, Dr. Varun Pushkarna, sir. He is a senior consultant in internal medicine at Fortis Escortis Hospital, Amritsar. His area of interest is in rheumatology, hematology, and cardiology. And today's topic is about nephrology. Over to you, sir.
Good evening, doctors. Good evening, Fatima. Good evening, everyone. So today's lecture is about nephrology. So I'm sure all of you must have read and gone through nephrology in a good manner. But honestly, when you come about nephrology, it is a very, very interesting subject when it comes to MRCP questions. There are certain lab-based queries which are usually asked in the exam and decision making based on them. So when you see a patient who is having renal dysfunction, it could be acute renal dysfunction, it could be chronic renal dysfunction, or there can be a third category which is rapidly progressing renal dysfunction. So when you get a question in scenario based, you will be given a history of previous illness or previous health, and then they will tell you that the patient has developed some cardinal features of renal problems like edema. Edema means swelling of the body, which could start with the feet or start with the face and then involve whole of the body. Second is uncontrolled blood pressure. Third is, of course, fourth is presence of blood cells in the urine, which could be microscopic or macroscopic. And fifth is, of course, problems associated with the urinary tract. That, of course, is a part of genitourinary medicine, but many times nephrology questions can be asked from them. So the major crux of the questions will be revolving around the presentation of the disease. That means what the patient will come to you, the problems that the patient will come to you with. They are mainly 5 of them. One is, as I told you, increased frequency of urine, hematuria. Third is this presence of froth in the urine, too much of foaming of the urine. Then, of course, lack of urine production. And fifth is swelling of the body along with increased blood pressure. So these are the cardinal presentation. So whenever there is a question which is revolving around these topics, you must think of that this is coming from nephrology. And we'll go through the questions and then we'll see how this thing that we just discussed will be seen. So a patient with end-stage renal failure. So can anybody tell me what is end-stage renal failure? So when you see a question, this end-stage renal failure is a diagnosis. We must understand what is being asked in the question. Anybody? What is end-stage renal failure?
eGFR below 15.
Below 15. So rightly said that eGFR or GFR less than 15, it constitutes end-stage renal disease. So this is end-stage renal disease. So we have an end-stage renal disease. Immediately when somebody says ESRD, you should talk, your mind should say that yes, GFR is less than 15. Okay. Patient on hemodialysis may have anemia. So that's a very common problem of these patients who are on dialysis, that is anemia, secondary to multiple causes. So one of the important causes is erythropoietin deficiency. Now, erythropoietin deficiency can be counteracted by erythropoietin injections. Which of the following blood tests in conjunction with serum ferritin is the recommended test for status of iron in patients with anemia? Is it serum iron? Is it transferrin saturation? Is it CRP, ESR, or mean cell volume? So how do you
Saturation.
Wonderful. Very good. So the answer is transferrin saturation. Rightly said. So transferrin saturation less than 20% is used in conjunction with the serum ferritin to assess the need for iron replacement in the patients who have problems of anemia in the CKD. Now, this anemia of CKD is a very important topic. You can mark it down, you can write it down as one of the important topics for preparing for MRCP. So, anemia of renal disease is a hypoproliferative anemia. That means it's a bone marrow which is not working up to the mark. So, it's a hypoproliferative anemia resulting primarily from deficiency of erythropoietin, or the response doesn't come. Erythropoietin is there, but the bone marrow has become resistant to it. Then it tends to be normocytic and normochromic. This is an extremely important question which has been asked multiple times in the question, that anemia of renal disease is of which type? Microcytic, normochromic, microcytic, hypochromic, macrocytic, hypochromic, macrocytic, normochromic. So all these permutations can be asked. Anemia of renal disease is usually normocytic, normochromic, and the treatment includes the measure to correct the underlying disorder, that is the renal dysfunction, and supplementation of erythropoietin and sometimes iron. Although what happens usually is people in India, they are chronically iron deficient even normally. So when they develop kidney disease, they become iron deficient in a very, very big manner. So iron deficiency is the norm generally in Indian subcontinent, but when they have CKD, we do see that there are other causes of malabsorption, erythropoietin deficiency. These people, they have bleeding tendencies also, so they can be having GI bleeds, so they continue to deplete iron also, and then anemia happens. According to the guidelines by NICE, serum ferritin is to be seen with either transferrin saturation or the percentage of hypochromic red cells to assess iron deficiency, not anemia, but iron deficiency. Low mean cell volume can be an indicative of iron deficiency, but that we call microcytic. So when you see microcytes in the PBF of a patient of CKD, that implies iron deficiency, which may be an attributable cause. So this is incorrect, because this can be, iron deficiency can be because of nutritional anemia, iron deficiency can be because of so many other reasons, but to specifically define anemia of renal disease, you need to see that the patient's transferrin saturation is low, the ferritin is also low. Serum iron, although marker of iron status, is not a recommended test. It is incorrect, because this iron may not be, the reason for anemia in CKD. Iron may be even normal. A 22-year-old ice skating player presents to the sports medicine unit with frank hematuria. See, I told you this is one of the cardinal presentations in nephrology. So frank hematuria means red urine. Now, can anybody tell me the differentials of red urine in a 22-year-old young man?
Rhabdomyolysis.
Okay, so that is actually an
For
extreme,
athletes.
yeah, that is one of the extreme causes. Think of more common things.
UTI infection,
Very
urinary
good.
tract infection.
UTI infection, stone, renal stone, then the other conditions. Yeah. So if I have to draw you the causes of hematuria in any adult patient, we'll start with the kidney. So the reason can be in the glomerulus or outside the glomerulus. In the glomerulus, one can see glomerulonephritis, because glomerulonephritis is one of the cardinal features is hematuria. Specifically, if the patient has nephritic syndrome, then IgA nephropathy. Now, these are all renal causes within the glomerulus. Then very common disease, most common worldwide, is thin membranous disease. So thin membrane, the glomerular basement membrane is thin. It is the most common reason for non-pathological hematuria in adults. Thin basement membrane disease. Then a rare inheritable causes Alport's syndrome. which is also very common for MRCP. So Alport syndrome is a congenital problem where the collagen is deficient, the type of collagen is not right. So the basement membrane becomes weak. And because the basement membrane is weak, hence the patient develops hematuria. Now, outside the glomerulus, the reason can be a tumor, which could be benign or malignant. Then polycystic kidney disease. Then sickle cell disease, very important reason for hematuria. So sickling crisis can produce hematuria. Then pyelonephritis. So this is outside the glomerulus, but within the kidney. Then of course, renal stones, that is renal lithiasis. Renal papillary necrosis, a very important cause in diabetic patients. And of course, kidney trauma, direct blunt injury to the kidney. These are the causes of hematuria happening from the kidney. Now, can somebody tell me the cause of hematuria in the ureters?
Stone. Stricture.
Okay. So let's start with the tumors of the ureter. Then, of course, the stone. Then the stricture. Then the infection, ureteritis. And of course, trauma. Down below is the bladder.
Cancer.
So, okay, you start with the
Stone.
tumor, exactly. Stone, infection, and
Cystitis.
trauma.
Trauma.
Then here lies the prostate. So any reasons for the prostate? Again, prostatic cancer can be a reason for hematuria.
Prostatitis.
And then, yeah, prostatitis, infection, and then the urethra, direct urethral injury, trauma and infection. So as we go down, trauma and infection increase. Of course, urethral cancers can also produce hematuria. Now, this is the list of diseases that can cause hematuria. As I always keep telling my students that you must remember the formula, vindicate them. I told you last time as well, I guess.
Yes.
Yeah, vindicate them. So V is vascular. So you can put anything into this formula. I is infection. N is neoplastic. D is degenerative. I'll put in all, here I is iatrogenic. C is congenital. A is autoimmune. T is traumatic. E is environmental. Another E is endocrine. And next is metabolic. So if I have to just place hematuria here, my list can be drawn very easily. So what are the vascular causes? Renal infarction, renal trauma, damage to the renal vessels, vasculitis, infections, pyelonephritis, ureteritis, urethritis, cystitis, prostatitis, all of them, neoplasms, cancers of the kidney, cancers of the ureter, cancer of the bladder, cancer of the prostate, cancer of the urethra, degenerative polycystic kidney disease, iatrogenic, any surgery, these pyeloplasties, PCNL, TURP, all of them will have hematuria. Congenital is thin basement membrane disease and Alport's syndrome. Autoimmune is, of course, all kind of glomerulonephritis that have an autoimmune basis to them. Trauma, yes. Hardly any environmental and endocrine or metabolic causes can be there. But this is the list how you can prepare for any medical problem. So this patient, who's a young guy, has come to you with frank hematuria that began some 48 hours after an upper respiratory tract infection. Does this ring any bell, anyone?
Yeah.
URI, frank hematuria?
Post-streptococcal.
IgA nephropathy.
Wonderful. So URI plus, I'll tell you, URI plus hematuria, okay, So age group is like below 10, above 10. Below 10, it is PSGN in the question, okay? Above 10, it is IgA nephropathy. Fair enough? You remember? Although this is not the norm, this is not the rule, but to remember for an exam, it is easy. If URI plus hematuria is happening in a young, less than 10 years of age, you think of PSGN. If it is above 10 years of age, think of IgA nephropathy. Okay?
Okay.
So our patient is a 22-year-old man. He had upper respiratory tract infection. Let's see his pulse rate is 70, his chest is clear, his abdomen is soft and non-tender. So hemoglobin is 14.2, total leukocyte count is normal, platelet count is okay, sodium is 141, potassium 4.2, creat 0.88, fine. Urine dipstick is 3+, blood. Okay, so what is the most appropriate way to manage him? So stage the disease. IgA nephropathy can be staged. Like just started, first event has been chronically present, hypertension, hematuria persisting. So just started, will you want to treat the patient? No, you will observe the patient. Because 70 to 80% of the patients, they have spontaneous recovery, self-resolving. Okay, so why it happens is because IgA is a mucosal antibody. We all know about it, right? It is a mucosal antibody. So whenever something is going wrong anywhere in the mucosa of our body, there will be excess IgA produced. And what will this excess IgA do? If the person's kidney can handle that IgA load, fair enough. Otherwise, this IgA will go and plug into the glomerular basement membrane and then leading to hematuria. Okay? So IgA excess ho jata hai, jiske karan IgA excess gets deposited in the kidneys, and then this leads to inflammation and hematuria. So whenever there is inflammation and hematuria and nephropathy, this leads to release of renin-angiotensin axis, increasing the blood pressure. But let us say if it is spontaneously recovering, then we will just observe the patient. If it becomes chronic, then we will start the patient on antihypertensives, that is telmisartan, to decrease the proteinuria component. But if still it doesn't get corrected, then we go for steroids. Okay, so kindly tell me, out of these options, which one suits my patient the most? He's a 20-year-old player. He went on to play, but then he had URI, he had hematuria. He's just come to you that I have hematuria for last 2 days. What will you do? Will you observe? Will you start the patient on steroids and cyclophosphamide? Will you put the patient on ACE inhibitors titrated to maximum tolerated dose when his blood pressure is only 110/70? Will you put the patient on high dose of steroid, which is equivalent to the body weight? Or start an ACE inhibitor titrated to maximal tolerated dose? Okay, so what is the answer?
Observation, sir.
Observation.
Yes, so logically the answer will be observation. So answer is correct. The boy has most certainly IgA nephropathy. How can we diagnose IgA nephropathy? The diagnosis will start with the patient's complaint. We understand that the patient has hematuria. We take a very good history and we define that the hematuria started after the patient had URI, or when the URI settled, hematuria started. It is painless hematuria. And you then what you do is you measure the blood pressure. And if you want to diagnose the patient, you will like to do a renal biopsy. So this boy almost certainly has IgA nephropathy, given his presentation with frank hematuria occurring in close proximity to a URI infection. The findings of normal BP, normal creatinine, hematuria without proteinuria. So this to a benign prognosis, and hence this patient only requires monitoring. Steroids, I would start, or the recommendation is to start in patients with hypertension and worsening renal function. Okay, just to manage proteinuria, you can start the patient on angiotensin inhibitors or angiotensin blockers, never together. So it is and is written here, and is not the right answer, the option C. So and nahi, but it is or. Okay. So the answer is observation.